So anyway, we're going to move on to my talk. I'm going to be talking about the advances in the microsurgical management of lymphedema. No disclosures. So we already kind of talked about this, so I'm going to skip this, but basically many patients in the US are affected with lymphatic diseases, up to 10 million and 250 million people worldwide. The thing that is, I think, the most difficult patient for me when I see in the office is a patient with what I call venous lymphedema or phlebolymphodema. 1 in 3 patients with chronic venous disease have venous lymphedema. These are the most difficult patients to treat for me. At University of Miami, we have a multidisciplinary team approach for treatment. This provides the best care for our patients. We are also the first and only center of excellence designated by the Lymphatic Education and Research Network in South Florida. So first we have to talk a little bit about anatomy. So the lymphatics are just like veins. They have valves. They reside mostly in the subcutaneous tissues. And what they do is they move fluid, and they can do it through 2 ways. One is passive, through leg elevation, through pumping of muscles when you walk, through respiration, gravity. And there's also active movement of lymph fluid through actual smooth muscles around the collecting lymphatics. And you saw that on that ultrasound with the high-frequency ultrasound. And this is a nice study looking at lymphangiosomes of the lower extremities. So just like there's angiosomes and venosomes, there's also lymphangiosomes of the leg and arm, and they follow the superficial veins. The reason why this is important is when you're doing your venous ablations, whether it's thermal, you have to be careful you don't damage the tissues around it where there's lymphatics, which can lead to iatrogenic lymphedema, which I've seen in many patients after thermal energy devices. So lymphedema, as we talked about, it's not just a fluid issue. It starts with fluid, but leads to fat and fibrosis. And we have to think about this because we treat this differently, surgically. This is a nice paper looking at lymphatic vessels in a normal patient up to late stage. So early stage, you can see the nice supple lymphatic. As patients with early stage lymphedema, they get these what's called ectatic lymphatics, where they're dilated because there's back pressure. That's the best time to perform lymphovenous bypass because 1, the vessels are larger, and 2, it's still early in the stage. However, as you move on, you can see the vessel becomes contracted and then ultimately cirrhotic. It's a solid pipe. You cut into it and there's nothing coming out of it. At that time, there's no way you can perform a bypass because there's no fluid even in it's a non-functional lymphatic. This is a nice cross-section of a patient with lymphedema in one leg, and you can see how much fat and fibrosis develops in that leg. This has already, I'm going to skip this for now. The one thing I do stress when I work with patients with lymphedema is you have to make sure the venous system is competent. So I do get duplex ultrasounds on everybody. I get CT venograms on select patients, and it's because you want to rule out other reasons. And also, number 2, the surgeries I perform divert fluid into the venous system. So you have to have a competent venous system for the surgeries to work. For example, here's a patient who presented with bilateral lower extremity edema. We get a CT scan and she has a large uterus. She gets a hysterectomy and her swelling goes away. So we have to remember that lymphedema is not always the diagnosis. This is a paper that we published recently in the Journal of Vascular and Venous Lymphatic Disorders. Basically what we did was we reviewed 121 patients who were presented to our lymphatic center, and we obtained lymphocytographies, duplex ultrasound, and CT venograms on everybody. And we wanted to see what was the incidence of these positive findings. So in terms of lymphedema, 49% of patients was diagnosed with lymphedema based on lymphocytography. 44% of patients had venous reflux. So remember, these are all lower extremity lymphedema or limb swelling patients. 11% of patients was diagnosed with May Thurner based on CT venogram. Our cutoff was 50% stenosis of the common iliac vein. And then, however, we reviewed those patients with a vascular surgeon, Dr. Shao, who's on this paper, and we determined that only 2.5% of the total patients that we obtained imaging on had clinically significant May Thurner, meaning they underwent a venous a venogram and an intravascular ultrasound and possible a stent. Early stage lymphedema is mostly swelling, and then later you can see it's mostly fat and fibrosis. So treatment, we all start with non-surgical treatment, but there are also surgical treatments for lymphedema. The ones I'm talking about is lympho-venous bypass and lymph node transplant. So what are the goals of surgery? 1 is prevent progression of the disease. 2, decrease limb volume and symptoms for the patient. And ultimately, the most important thing we're trying to do for our patients is really improve quality of life. So I get patient-reported outcomes on everybody before and after surgery. We use the lymphedema life impact scale because in the end, what we're doing the surgeries for is to improve their quality of life. So indications, patients have to undergo non-surgical management first for at least 6 months. And then they have to be compliant because I tell patients 1/3 is therapy, 1/3 is the patient themselves, and 1/3 is the surgery. You have to be compliant with therapy in order to have a good result. Their BMI has to be less than 35. If they're obese, it's not going to work. They have to have realistic expectations. These surgeries are not a cure-all. They have to have a competent venous system, so I work them up for venous diseases. If they have a venous problem, I send them to my vascular surgeon who will fix their venous system, and then I will perform lymphatic surgery on them. And then they have to be a good surgical candidate. This is elective surgery. This is not a life-saving procedure. So everybody that, before surgery, I will perform an ICG lymphography. And this is I think everybody, I know we don't get lymphocytographies everybody, but this is a study that I have to do on every patient before I perform surgery. And the reason is because this helps me determine what surgical options I have for that patient. So you can see early on, stage 0, you have nice linear lymphatics. However, as you progress throughout the stages, you can see there's more and more dermal backflow to the point where there's no linear lymphatics. When there's no linear lymphatics, you can't do bypasses. So early stage, I offer lympho-venous bypass. Late stage, I offer lymph node transplant or liposuction, depending if they're fat dominant. And then most of my patients currently are getting both bypass and lymph node transplants. And then later on, a year or 2 after, their fluid is improved, then I will do liposuction to remove the fatty component of their lymphedema. So here's one of my patients with breast cancer lymphedema. She has swelling of her left arm. We do a ICG lymphography. You can see she has nice linear lymphatics until you get to the elbow where she has dermal backflow because there's an obstruction of that lymphatic pathway. So we do a lympho-venous bypass. This is done under the microscope. We use Lympho-Venous suture, and this is one of her bypasses. Usually I try to do 3 to 4 bypasses per patient, and I'll tell you why later. This is one of their bypasses. This is an end to side bypass, so the end of a lymphatic to the side of a vein, and we confirm that it's patent. So the first thing that she noticed is she could wear her wedding ring, first time in 5 years. So she starts improving her swelling. However, she still has all that fatty tissue in the upper arm you can still see. That's not going to go away with the surgery. This only fixes fluid issues. It doesn't fix the fat. So we come back, we do liposuction, and you can see after we liposuction, their arms are much improved. Here's a patient who has gynecological cancer lymphedema. She has swelling of her right leg. We perform we do the ICG lymphography and perform multiple bypasses. This is the best configuration for a bypass if I can do it, and we call it a side-to-end anastomosis, so the end of a vein to the side of a lymphatic. You need a big lymphatic in order to do this, so anything, the lymphatic usually greater than 0.5 millimeters is possible, and a vein obviously that is reasonable in size. And you can see here's a side-to-end anastomosis. The nice thing is you don't have to cut the lymphatic, so you preserve the lymphatic pathway, and you're just diverting fluid that needs to go into the vein as needed. We come back and do liposuction on the patient, and here's her after bypass, 1-year bypass, and 2 months after lipo. So this is the landmark study published from Andy Anderson looking at 100 patients who had LV bypass surgery. Basically, the takeaway is patients improved in volume. 74% of patients improved in volume. You can see the reduction over 12 months, and 96% of patients improved in symptoms. So whenever I give this talk, vascular surgeons will always ask me, what is the long-term patency? Based on these studies, the patency about 26 to 49% at 6 to 24 months. The patency does decrease over time. It's better around joint areas where there's movement around the joint. Patency does correlate positively with subjective edema improvement, but does not significantly correlate with edema volume reduction. What about does size matter? Yes. There was a study that looked at 1,048 lymphatic vessels, and what we found is functional lymphatics were greater than 0.5 millimeters. And there was improved outcomes when you performed more bypasses. However, it plateaued at 3 bypasses. This is why I performed 3 to 4 bypasses per patient. I'm going to move through this quickly because of time. Lymph node transplants. So what I do is, for patients who are later stage, I perform lymph node transplants. Early on, I use the submental lymph nodes, which are off the facial vessels, and I connect it to the brachial vessels. Here's one of those patients. You can see 1 year post-op, she's got good improvement. However, now I transitioned to using the supraclavicular lymph nodes because it's a better donor site in terms of scar location. However, it is a very difficult dissection. It's deep. The transverse cervical artery is coming off the subclavian artery, so it's a deep dissection, and the anatomy is very variable, but it works very well. Here's a patient pre-op, after lymph node transplant, and then after lipo. So you can see, I just want to show you this video of how supple her tissues are after these procedures. Here's our this is a study that we published looking at our technique, and then if you look at lymph node transplant, the volume reduction is about 20 to 58%. And this is the largest study looking at both lymph node transplants and bypasses, showing the same thing. 87% of patients reduce in lymph volume, 86% of patients improve in lymph impact scale, which is the quality of life measurement scale. The last thing I want to show is, this is the newest thing I do now, is using groin lymph nodes. I make sure these are lymphatics that drain the abdomen and not the leg. I use ultrasound to find my vessel. So now I'm transplanting both the lymphatic vessel as well as the sentinel node draining the abdomen, not the leg, draining the abdomen. We do reverse mapping to make sure we're not taking any lymph nodes that drain the leg, and then we transplant that to the arm. So we're waiting for our data to come out, but hopefully we'll be publishing this soon once we get long-term data. Thank you.